are being presented with. Our next speaker, once again, knows no introduction. Johanna Westbrook from Macquarie University is going to give us a presentation on the use of electronic health record data in aged care to monitor and improve quality. Very current discussion, particularly given the results of the Royal Commission and the current additional funding that's been put into aged care. So over to you, Johanna.
Thank you very much, Annette. So I'm really pleased today to be able to give you a brief overview of one small section of the research that we've been undertaking as part of the analytics and technology stream, which is focused on aged care, and particularly how we can better use electronic health record data in the aged care sector to look at improving quality and safety. One of the, as Annette said, one of the issues that came out very clearly in the Royal Commission was that we really don't have a very good handle on quality and safety in the sector. We don't have good monitoring systems, and yet we know that it's incredibly data rich in terms of all the pieces of data that are collected in the sector, but we're very information poor. So we've been really interested in trying to look at how technology can help this sector. And particularly as many aged care providers are using electronic health record systems. And so we wanted to look at how we can start to demonstrate through exemplars how this data can be used to really identify whether people are receiving evidence and value-based care. And particularly today I wanted to focus on medication therapy. So there were 4 challenges that when we started to look at this electronic health record data that we really realised we'd have to tackle. And we were taking a very pragmatic approach because clearly we recognise, and the work of Len Gray and his team in terms of trying to look at how we can set up a much better infrastructure, information infrastructure across the sector is the long-term goal. But we also have a short and medium-term challenge about how do we get better information because we need it now, and aged care providers want that information, and so do consumers. So we identified 4 immediate challenges that were preventing the sort of really useful use of some of this data in the sector. One of them was that just trying to work out what types of conditions residents have. And the challenge is that in these systems, often residents' conditions are entered as free text and often in non-standard ways. The second challenge is that because of the way the funding model works, there's only an incentive really to collect information about a maximum number of conditions, and they are entered in a certain area of the system. And then a lot of the other comorbidities, which are very important for the ongoing management of residents, are collected in another part of the system in a non-standard way. So we needed to look at how we could bring that information together to get a more comprehensive view of residents. Third challenge was the medication data, which is around what medication residents are actually being administered, are often not linked to the same information about residents' conditions. So we needed to bring that together. And when we started to look at that medication administration data, we also found that the systems weren't designed very well in the sense that the back-end classifications of the drugs was very poor. And we needed to classify them in a standardized way if we were going to make that information useful. So how have we gone about approaching this? Well, the first was to tackle this issue of trying to work out what types of conditions residents had. And so we've been developing an algorithm or a macro, which basically takes the free text data in these electronic health record systems, reads the information in the field that's often called conditions notes, takes the conditions information that are recorded in the financial part, the ACFS records of the electronic health record, and also looks at the medications that residents are on, because that will also give you information about what conditions they're being treated for. So we developed this macro, we applied it to a data set which comprised data from 68 residential aged care facilities, over 9,000 residents, And that allowed us to then start to report what is the prevalence of over 60 conditions and what were the most common conditions. I'm going to show you a little bit of that information in a minute. What's incredibly important, and goes to Enrique's point, is this replicable? Can we take this same macro and apply it to another aged care provider's data and also show that it's useful? So we have now done that as well. So we took a completely different aged care provider and applied it to their data from 20 aged care facilities and found that it also was very useful in being able to identify residents' conditions. So we are continuing to refine this macro, validate it, and also what's important is to make it publicly available. So we're interested in designing, really practical tools that people can start using now, rather than wait for the perfect system, which we're all trying to design down the track for aged care. But these are ways that we can start using this electronic health data usefully in the short term. So the macro is available on the Institute's website, and there's a lot of detail about behind the macro and what it does and how you use it, and we will continue to upgrade that as time goes on. This is one of the papers where we reported what are the most common conditions that people in residential aged care facilities have. Top of the list is constipation, and there is the list. And so it's really useful to start having some more detailed information about this, which is also contemporary information. So you can run these reports quite, on a regular basis if you wanted to. Okay, so just to mention then challenges 3 and 4, which was really starting to look at what medications are residents actually receiving, because primarily the sector's been relying upon looking at PBS data, which is what medications people are prescribed. But we do have this really valuable data set from residential aged care facilities which reports what medications residents actually are receiving. We've gone in and developed a mapping process where we can take the medication administration data and map the way the data is collected to the WHO's Anatomical Therapeutic Chemical Classification, so they're ATC codes. And really the value of that means that we can start doing some new reports for facilities. It means that we can look at people's conditions and look at the medications that they're actually on. And this is when we can start to gain a picture of, are people receiving evidence-based and value-based medication therapy? So let me give you some really practical examples of this work. So one area everybody's been very interested in is the use of antipsychotic medication use. Many groups have reported broadly the prevalence of antipsychotic use in the sector. But what we can do by looking at the administration data is to actually look at details such as how long people have been on these medications. So in this study, what we did was we looked at the Choose Wisely recommendations, which recommend that you should really be on only short-term targeted use of antipsychotics for behavioural and psychological symptoms of dementia. So we looked at a sample of over 5,800 residents with dementia. We looked at some of their comorbidities, and we looked at the extent to which they were using antipsychotics and for how long. And here you can see the graph of, we can look at by your gender with different types of comorbidities. And what we found was we can look at the average time to initiate the use after people are admitted to residential aged care. So for females, it was over 300 days. For males, it was over 170 days. Looking at 68 residential aged care facilities, the prevalence of use of antipsychotics was between 27.6% to 32.6%. And then we looked at, of those people who received an antipsychotic, 65% of them had been using that antipsychotic for over 3 months, and the average duration was 7 months. So we can start to see that really the use of these medications was not consistent with recommended guidelines. And we can also demonstrate that this is data and these reports that could be a standard reporting for an aged care facility that had an electronic medication administration system. and we've produced a model for doing that. Another example is to look at osteoporosis at treatment in residential aged care. And so here we were looking at, once again, all the residents with a diagnosis of osteoporosis, what proportion of them were receiving various medication over time. And once again, it gives you a sense of, are people receiving appropriate care for their conditions? And a third example is antibiotic use. So there's enormous concerns about the overuse of antibiotics, particularly in residential aged care. So this work demonstrated the proportion of people in these facilities that had received antibiotics. We can look at it over time. And what we found is, while there's been a slight decrease in use, we found that on average residents was using antibiotics for longer. And the value here you can see is you can look at the variability between different aged care facilities. And also we can adjust for important resident characteristics or conditions. And this means that it's valuable comparative data for the aged care providers. It gives them a sense of where they should be targeting their efforts, which groups of GPs perhaps they should be having discussions with. And it provides them with contemporary data rather than data that might be 2 years old. It also means that once you start to look at various interventions, you can use this data to see whether it's actually making a difference and give feedback to people about the effect of those interventions. So our objectives of this part of the program of work has really been looking at, can we deliver some generic products to the sector, working with them about what type of tools would be valuable for them in order to target their quality and safety initiative. But we want tools that potentially are applicable to a wide part of the sector. It's also very useful by having real examples of how this information can be used to drive improvements in clinical system design for the sector, to demonstrate what is possible and really how the reporting out of these systems, the coding and classification systems behind them, really needs to improve. And also importantly, to look at how you can use really quite straightforward sort of statistical processes built into these systems to account for things like confounders, which allows meaningful comparisons to occur. A third thing is to start to build the capability in the aged care sector of using data, of presenting it in ways that is meaningful to them, and to increase the skill capacity to use data to inform various safety interventions. And finally, it's to start saying there is a lot of really valuable data available to use for quality indicator monitoring, and that we shouldn't be necessarily getting people to collect independent data sets or to be undertaking separate one-off audits. We should be investing in improving the quality of the electronic data in the sector and get better value out of that data. So that's a very brief overview of where we're going. Thank you. Over to you, Annette.
Thanks, Johanna. That was very brief but very comprehensive. And I noticed Amy Coops had a tweet that she said we need to storm the Bastille. So hold that thought and have a think about what we might do to do that. Our next, now we're going to have, who's next?